Let me welcome everybody to the inaugural session of the Colloquium for National and Global Health Law. I'm John Monahan, Executive Director of the O'Neill Institute. I co-teach this class with Professor Gostin. I also want to welcome everybody else here who's joined us. We can't imagine a better kickoff to this class and this series than to have Dr. Fauci with us. And so I'm not going to take up any more time other than to turn this over to my colleague, Professor Gostin, for introduction and to set up our discussion for today. To thank everybody for coming. We're looking forward to a very interesting and insightful discussion.
Well, welcome to the first session of the O'Neill Institute's Colloquium on National and Global Health Law. And just to let you know a little bit how it works before I introduce Dr. Fauci. The purpose of this is to bring national and global leaders to Georgetown, to the full Georgetown community. I know we've got a lot of people from the main campus here, which is a delight to see, and law students. What we will be doing with each session of the O'Neill Institute Colloquium will be slightly different depending upon the speaker. Today, what we're going to do is Dr. Fauci is going to on questions of infectious diseases with a PowerPoint and a lecture for about 25 minutes. Then he and I will engage in a conversation, a pointed conversation about the issues. Then we will transition to questions and discussion from the audience. The students in the colloquium have the first crowd every session, the whole point of it. And then we'll bring in the greater Georgetown community and Washington. We welcome you. It is my very great pleasure to introduce Tony Fauci. Anthony Fauci, the Director of the National Institute of Allergy and Infectious Diseases at the National Institute of Health. This room will know Dr. Fauci by reputation. He is a key advisor to the President. Remind me that when PEPFAR, the President's Emergency Relief Program for AIDS, was recently authorized for, I think, $48 billion. And I say that maybe the person who had the inspiration for PEPFAR and worked with the President, Dr. Fauci, is a great historical achievement. He is a key advisor to the President on many issues, successive presidents, an advisor to the Department of Health and Human Services. Many of you, all of us, will know him being a public spokesperson. He is really the face of public health in America. So much so that Saturday Night Live did a caricature. Probably didn't see that one, did you? I just happened to see it. But it was a very good likeness. He is a man of really many talents. He is a scientist, first and foremost, with an impeccable reputation among the scientific community and as well as the clinical community. A member and an influential member of the Institute of Medicine. He's a policy person who thinks carefully about policy in the U.S. and internationally, and has been very much involved in America's preparation for polypathogenic influenza if it comes. He's a humanitarian. He's done as much as anybody I can think of for global health, and I'm proud to say that he's a friend. So welcome to Georgetown, Tony, and I'll turn it over to you.
Thank you very much, Larry and John. It's a pleasure to be here with you this afternoon. As Larry said, the issue for today, for this afternoon, that we'll be discussing during the discussion period is global health and infectious diseases. And I underscore and infectious diseases because there's a lot more to global health than just infectious diseases. But for the purposes of the discussion today, we're going to concentrate on infectious diseases. And as you can see from the title on this particular, its challenges and opportunity. So I'd like to present to you, as Larry said, for about 20 minutes or so, sort of an overview of global health and the relationship between global health and infectious diseases to perhaps serve as a framework for some of the discussion that we'll have. Well, first of all, it's very clear, if you look historically, that the infectious diseases, particularly major epidemics that is antedated our understanding of even the germ theory of disease, of infectious diseases, has shaped societies throughout the world. We all know the histories of plague, how it had such an extraordinary impact, particularly in Europe and in Asia, measles and smallpox in the New World, the influenza pandemic, which is the most recent, notwithstanding AIDS, which we'll get into in a moment, but in 1918, 50 million to the pandemic flu of 1918, 1919. So it's very clear argument that infectious diseases, in fact, shape and has shaped and continue to shape societies. Importantly, that they have an extraordinary amount of progress in the control of infectious diseases. I've listed 5 bullets on this slide that are really major. First is actually the germ theory, to realize and know that microbes actually cause many serious diseases, in addition to improvements in sanitation, hygiene, vector control, particularly mosquitoes, with all of the deadly mosquito-borne diseases, the discovery and development of antimicrobials, vaccines, vaccine programs, and the advances in detecting and monitoring diseases. So we've come a long way from the time when we didn't even know that microbes caused disease that devastated societies to doing a spectacular job, particularly in the developed world, of getting our arms around these infectious diseases. And in fact, I cannot give a lecture or a discussion on infectious diseases without bringing out something that really tells you a little bit about how we as a modern society think. It was the conventional wisdom around the 60s or so, in the middle 60s, that the war on infectious diseases was over. This is a quote just from one of many scholars who actually said in a very well-respected treatise that we can look forward with confidence to a considerable degree of freedom from infectious disease. In fact, you can anticipate that within some measurable time, all the major infectious diseases will have disappeared. Now, retrospectively, I have a personal issue with this because a couple of years after he said that, I had just finished medical school and my internship and residency and was on my way to the National Institutes of Health to take, of all things, an infectious diseases fellowship. It's like somebody telling you that from now on there's going to be no law. So, but go ahead, go to school. So this is what I was faced with when I was doing it. But what it tells you is really something sad about our society, that we here in the developed world could actually say that as each year 1.3 million people die of malaria, mostly African babies, 1.5 million people die of tuberculosis, and we hadn't even had AIDS at the time, and we were talking about the victory against infectious diseases, a very provincial look at the world. This is the country hopefully we'll get into in the discussion on what we mean by global health, because we in fact indeed live in a global society, not only from the standpoint of humanitarian reasons, but for a variety of other reasons which we'll get into. So these are the actual numbers. The last count by WHO, 57 million deaths per year in the world. 26% of them are due to infectious diseases. It's the death worldwide, the first leading cause of death among young people birth to 45 years old, and overwhelmingly the leading cause of what we call DALYs, which is disability-adjusted life years, or namely years of illness. So it is overwhelmingly important. Now, the way I look at infectious diseases, I tend to break it down empirically and somewhat artificially into what I call established infectious diseases and emerging and re-emerging infectious diseases. So after a new re-emerging disease comes, after about a quarter of a century, from an emerging established disease, whereas others that just prop up. So let's take a look at some of them. If you look at the deaths we were talking about, respiratory illnesses, again, particularly in the developing world, HIV/AIDS, which 20 years ago, if I was giving this discussion to you, I'd call it clearly an emerging infection. I put it now under infectious diseases, diarrheal diseases, TB, malaria, neglected tropical diseases, all things that we could discuss during the period. The impact is particularly important in the developing world. If you look at the total deaths, 10.8 million in sub-Saharan Africa each year, 63% of them are due to infectious diseases, and of the total deaths of children worldwide, children meaning less than 5 years old, 62% of these are infectious diseases. So if you're poor, if you live in a developed region, and particularly if you're a child, you are greatly threatened by infectious diseases. The reason that this is important is that this is one of the things that we actually can do something about. I mean, it is unlike other diseases, the development of cancers, the development of Parkinsonism, of Alzheimer's, or what have you. Infectious diseases are eminently controllable if you take the right approaches. In addition, another issue that again strongly relates to global health is the extraordinary connection between poverty and infectious diseases. They reinforce each other. A country that's burdened by infectious is economically not nearly as productive as one in which is a healthy society. And when you're burdened by poverty, you get more of a chance of getting infectious disease. So it really is a vicious cycle. In fact, if you look at the numbers and the life and deaths in the poor and richest was on the slide, if you compare the 50 least developed countries with industrialized countries, look at the annual per capita income is 383 versus 35,000. A couple of orders of magnitude different. The life expectancy is extraordinarily different, 26 years delta, and the under 5 mortality rates per 1,000 live births is 153 compared to 6. Amazing discrepancy and amazing disparity when you think in the terms of the role of poverty in health. So just from a semi-philosophical standpoint, the infectious diseases people like myself tend to think metaphorically when you're thinking about microbes and why we continually, despite our extraordinary technological advances, challenged by emerging and re-emerging infections. And that really has to do with the evolutionary capability of microbes to emerge and re-emerge. And it's because they have an amazing capability of replicating and mutating. What we have on the balance of this delicate balance between the microbial and human civilization is we have our intellect and our will, public health measures, research, and technological. So let me just spend a minute on emerging and re-emerging infection. This slide here is one that I show every year to the Congress when I argue for the budget of my institute. And you might say, don't they kind of get bored at this? And the reason they don't get bored is that every year I add 1, sometimes 2, sometimes 3 new infectious diseases. And I started off making it 20 some odd years ago with HIV/AIDS, and now I have to start clicking off some of them because I can't fit it all on the slide. I tend to break it up into what's truly a newly emerging disease. A newly emerging disease is one that we've never seen before. It's the mother of all newly emerging diseases. Major impact that we're still feeling. SARS is another example of a newly emerging disease that we had never seen before, but luckily for us, it lasted 1 year and only 1 year. It had more of an economic impact than it did have a public health impact. What's a re-emerging disease? A re-emerging disease is one that's been around for a long time, but it reappears in a different setting, in a different form. all in this room have experienced is West Nile virus in the United States. For centuries and centuries, in fact, before recorded history, West Nile virus and in the Middle East. Only in 1999 did it first come to the United States. And then there's the issue of other deliberately released microbes, such as the threat of. So what about global health? And why is it important for us here in the United States and in the developed world to be interested in global health? Well, when I first started arguing about this more than 20 years ago, and it was usually in the context of a congressional hearing to global health, I somewhat naively thought that humanitarian objectives would sustain the interest in global health. It does it a little bit, but it's a non-sustainable. People can only worry about humanitarian issues until something else catches their attention. Along is the relevance to domestic health. Can something start over there and come over here? The big wake-up call was HIV/AIDS. HIV/AIDS come, we didn't realize that it started over there and came over here, because the first cases of HIV were actually noticed in Los Angeles, San Francisco, and New York. Nonetheless, the idea of danger to us. But the thing that's really sustained the interest in is the fact that we in fact live in a global society, and there is an extraordinary amount of impact economically, and why a healthy society is a society that would have an impact on us. So if you have major investments in countries in which malaria is devastating the population, it's a big risk to get involved in investments in those countries. So people who are healthy in Southern Africa or in Asia or in all of a sudden become very relevant to the people who have a lot of money, who are very interested in the kinds of economic impacts that you see with globalization. So the last 10 years has really been a galvanization of broad-based interest in global health. Everything from the UN to the G8, the United States government, philanthropies, you name it, global health is the issue. Everyone is interested in global health. I say that now they are, and that's one of the things I'm going to close up with. This is a picture of Bono with his red credit card. I mean, when you see that, but he's actually had a major impact on raising awareness of the importance of rich countries, of trying to help developing nations, not by giving them things, but by helping them to become sustainable in and of themselves. And that's a critical issue and a lesson that I hope we get a chance to discuss during the discussion period, about how the new approach to how you give aid, we don't call it aid anymore, it's really more of a partnership with developing nations about how to get them to self-sustain. It's been such an important awareness now of global health that I show this almost symbolic. Science magazine, which along with Nature is one of the two top scientific journals that we scientists all read. At the same time, magazine both had feature articles on global health. So as I mentioned, it really is important. I'm going to take 3 examples of what we call AIDS, malaria, and tuberculosis. This is a historic slide in the historic. What's on the slide is historic. Is that the very beginning, when I first heard about HIV, was reading the June 5th, 1981 issue of Morbidity and Mortality Weekly Report, which is a CDC publication that comes out every week and tells you about contaminated spinach and wherever, lettuce and diarrhea and salmonella. This one hit us that there was 5 cases in otherwise well gay men in Los Angeles infection called pneumocystis pneumonia, which is only seen in immunosuppressed people. And then a month later, on the 4th of July, there were 26 cases, not only in New York, but also not only in Los Angeles, but New York and San Francisco, not only of pneumocystis, but Kaposi sarcoma. The reason I show it to you is that it was at that point that I think historically, even though we didn't realize it, became the revolution, as it were, in understanding the importance of global health, because it took us a few years that it wasn't predominantly a disease of gay men in the United States, that it actually was a heterosexual disease predominantly, where 90% of the developing world and 67% of the cases were in sub-Saharan Africa. So although the new infections in this country are still 53% of the new infections are among Worldwide, it's about 50-50 men and women, usually heterosexually. These are the numbers. There are 33 million people infected with HIV. The federal government has spent an enormous amount of money over the last 28 years. You see, what's up there? You see early on in the very beginning, we're not spending as much as we thought we should. And I see my friend Tim Westmoreland back there. When he was working for Henry Waxman, we used to have some interesting discussions about the fact that I worked for the federal government and the federal government was doing enough. I still feel pain when I see Tim. Just kidding, Tim. No, actually, Tim worked for Congressman Waxman and was one of the major figures in attention to what we needed to do with HIV, so I meant that as a really strong compliment to my friend. The NIH has spent also a considerable amount of money, about 36 cumulatively, on HIV, and I run through these and show you this for a reason, and it'll become obvious to you in just a moment. Because advances in AIDS research from 1981, based on the enormous amount of resources that were put in it, is actually breathtaking. We still have major problems with HIV, which I love to talk about during the discussion period. But if you look at what money you put in, particularly in the area of treatment, it is unprecedented in the positive impact. And this is particularly seen in the that are now available for HIV infection. Do you know an interesting fact that very few people appreciate? There are more antiretroviral drugs, more antiviral drugs for HIV than the sum total of all antiviral drugs for all other viral diseases. That's not an accident. The reason it's not an accident is because an extraordinary amount of money was put into the development, and the drug company, oh my goodness, a drug that you're going to charge $15,000 a year for that people are going to have to take for the rest of their lives. I mean, it even beats Viagra, because people wouldn't take Viagra every day for the, I don't think so, every day for the rest of their lives. But this is something that actually transformed the relationship between investment and research. And the reason is I'm going to compare that to other things that we've done. The survival benefits have been extraordinary. This is a paper from a year and a half ago showing that in the United States alone, 3 million years of life, and when I say life, I mean healthy life, not people in bed, people going back to work, going back to school, being productive members of society, have resulted from the therapy that was developed by this industry and researchers funded by the federal government. The same holds true in Canada, in Europe, and in Australia. The real question is, what about getting this to people who need it? There was a historic meeting that took place in Durban, South Africa in July of 2000, where the African activist borrowed a page from the playbook of the United States activists, particularly people like ACT UP and Project Inform and people like that, who early on in the epidemic were demanding access even before they were approved by the FDA. Interesting chapter in history, again, that I'd love to get into the discussion with you about how the issues were transformed during the early years of the AIDS epidemic by insistence on the part of most of the community about the unfairness of how our rigidity from a regulatory standpoint was not allowing people to make choices with medications that we felt in a very pristine way we had to test exactly the way you test it in the normal way. I bring that up because the Africans were saying, wait a minute, why can't we have the same advantage that you do? We've gone now from it was uniform people living normal lives. We want access too. And that's how we got into the thing that Larry mentioned, the President's Emergency Plan for AIDS. It was really set out to prevent and has been extraordinarily successful. 7 million new infections, treat 2 million infected people, and care for 10 million. Not only for HIV/AIDS, but for tuberculosis and malaria, and a variety of philanthropies, including the Gates Foundation, Médecins Sans Frontières, and others. Such that now when the president sent me to Africa in the spring of 2002 to determine if we could do something on a broad scale, and that's how we actually got PEPFAR, there were about 50 people in Southern Africa who were receiving antiretroviral drugs. Now, in 2000, and at the end of 2007, on the Global Fund, there are over 3 million people who are receiving antiretroviral drugs. Now, there's something wonderful about that, but there's a problem about that. By the way, Larry mentioned that. Thank goodness the Congress has voted to reauthorize PEPFAR at $48 billion, which is really something that was absolutely necessary to do that. The issue is, when you treat somebody for HIV, you got to treat them for the rest of their life. And the numbers are sobering, because not only is only 30% of the people in the low and middle income countries who need to be actually getting it, we're doing better and better, because it was less than 4% when we did the original determination. Now it's at least 30%. The person we put on therapy, 2 to 3 people get infected. So you can't logistically or even financially maintain many more people getting infected than you're getting on treatment when it costs so much. So what is the answer to that? The answer to that is prevention. And that's one of the big critical issues I'll leave for us to discuss a little bit later. You don't need to go any further than where you're sitting right now to talk about some of the failures in prevention by not really being sensitive to the particular needs, risks, cultures, or what have you. Societies that find themselves getting infected with HIV. Washington, D.C. has the highest infection rate city in the country. There are some extraordinary numbers. This is true. Washington, D.C. has about 600,000 people in it. It's about 60% African American. When you talk about Africa, countries like Uganda and South Africa and Mozambique and places like that, when they talk about the percentage of the population infected, they usually say, well, 10% of the people from ages 15 to 49, sexually active people. In Washington, D.C., 5% of the entire population is infected with HIV. 5% of everybody who has an address that's Washington. It is extraordinary. Of the new infections in the United States, particularly in D.C., among men, 49% African men, and African Americans, as you know, comprise 12% of the population. Among women, 60% of the new infections. This is Washington, D.C. I put this little star there to show you the disparity of health in not getting to the... That star is in Northwest D.C. That's where I live. I live in the district. So if you do a satellite map, there's nice trees for those of you know, Avenue and Foxhole Road and all that sort of thing. In fact, that's actually my house there. So now if you go back up and look at the incidence of infection in the district, you see Ward 3, which is where I live. The lighter the color, the lower the incidence of. If you look at northeast, southwest, and southeast, the infection rate is worse than most African countries. And that is right here in the District of Columbia in the United States. So we have a lot of work to do when it comes to prevention. And again, we'll be happy to talk about that. Now, what are the issues of the money that we put into HIV? I didn't want to, for no other reason than it got me thinking a few years ago when I wrote a commentary in the Journal of the American Medical Association. I called it the AIDS Research Model, Implications for Other Infectious Diseases of Global Health Importance. And the point that I made, much to the dismay of some people in the administration, that if you actually put the same amount of money that we put in HIV/AIDS, could we do for other diseases like malaria and tuberculosis what we did for HIV/AIDS? And let's get back to this very, very briefly. What about malaria? Malaria has been there all along. Somewhat ironically, if not paradoxically, malaria and tuberculosis have benefited from what we've been doing with HIV/AIDS, because when we thought HIV/AIDS was a disease in the United States, and then as we realized that it was actually a disease of the developing world, we started to look to the developing world. We had a lot of projects over there, and when we got to Africa, when we got to South America, and we got to Asia, we were getting all excited about AIDS because we identified with AIDS, because we have over 1 million people in our own country infected with AIDS, and 500,000 of them have died. 1.1 million are living with HIV. All of a sudden, we started to see, wait a minute, there's 1.3 million people dying of malaria in these developing countries. And what about tuberculosis? So these are the numbers for malaria. This is 2008 numbers. Every 30 seconds, a baby dies of malaria, usually an African baby less than 1 year old. The president has started a malaria initiative, which is actually very well received in Africa, and it really is somewhat low tech, and that's spraying the inside walls of dwellings, insecticide-treated bed nets, based therapies, and preventive treatment for pregnant women. Bill and Melinda Gates have gotten very much involved, and they've actually galvanized the field and have really said, why can't we actually make a goal the eradication of malaria? It's something that no one ever thought would even be possible. It might not be possible. The fact that people are thinking about it is a very good thing. And there's been a significant amount of progress in malaria vaccine development. In other words, people are really starting to think about, if you could do it for HIV/AIDS, why can't you do it for malaria? Another interesting thing is tuberculosis. Now, if you look at this, another statistic, when I tell people who aren't in health, they say, this guy's crazy. No, I'm not. 1/3 of the world's population is infected with tuberculosis. So there's 6 billion people in this world, 2 billion of them are infected with tuberculosis. They're not tuberculosis, but they're infected with tuberculosis. And that's really a very important issue, because when you get HIV/AIDS, your immune system gets so devastated that you tend to reactivate latent tuberculosis. So we call it the twin epidemics of tuberculosis and HIV. Now, I really cared about HIV until somebody named Andrew Speaker got on a plane with his fiancée and went back and forth across to have extensively drug-resistant tuberculosis. He actually had multiple drug-resistant tuberculosis. Unfortunate for the young man and his now wife, but that got everybody energized. And I had the opportunity with Julie Gerberdine to testify before the subcommittee of the nation, and they were talking about, they were very excited about how could this guy get on a plane and nobody figure out that he had tuberculosis and put everybody else at danger, which gave us the opportunity to say that with 2 billion people in the world infected with TB, everybody in this room with somebody with tuberculosis, I will guarantee you. So rather than worry about that, why don't we worry about these numbers and do something about it? And that's actually what's happened, because we have really antiquated diagnostic drugs and vaccines for tuberculosis that we've got to do better on. And then finally, I want to close with another issue that, again, is attracting a lot of attention, and that is neglected tropical diseases. They don't kill as many people as malaria, tuberculosis, and HIV, but they are great maimers, and they are considering things like schistosomiasis, hookworm infections, leishmaniasis, things that are nagging on the productivity and the health of a nation and could actually be eliminated with pennies. You've heard about President Carter and the Carter Center eliminating guinea worm and river blindness by a drug that costs about 5 cents to administer, that we really need to start thinking about when it comes to the global health and international health, particularly with these diseases. So I'm going to close with a quote from a commentary that I wrote, when was that? Last October, on the global health agenda, a welcome development, I called it. And the point that I was making is that we have to keep this momentum going and recognizes that we still have enormous challenges in global health. But this is going to be a long-term commitment that must be sustained when global health and those fighting it are no longer in the headlines. So when the Bonos disappear and the Angelina Jolies disappear and the Brad Pitts disappear, we're still going to have the same problem. That's the reason why we really have to have a commitment that this is going to be something that is going to take decades and decades and decades of our commitment. So I'll stop there, and I'll be happy to get involved in this discussion. Thank you.
want to? We do. Well, thank you very much. You've covered a lot of things that I was going to ask you about, but don't worry, I've got plenty more. Well, why don't we start locally? Start with the districts that you up. Michael Marmot, who you probably know, a well-known British epidemiologist, pointed out that if you actually go on the red line from southeast to northwest, where we live, that for every mile you gain about 3 years of life. That's striking. What can we do about that? I mean, about disparities right here at home.
Well, the disparity, I'll stick with AIDS, but it really applies to everything else. It's very, very clear disparity in accessibility of health care and accessibility of counseling to things as simple as vaccinations for kids, drug treatment programs. The disparity between the American population and a white population, and particularly when you're dealing with HIV, is the extraordinary difficulty that you have with the African American of gay men in the African American population, because it's a cultural issue in which very rarely does somebody admit that they're gay when they're gay, in the sense that they lead a life where they are, at times of their lives, they're leading a heterosexual life, and at other times they're a homosexual life, so you could consider them bisexual, but they're in fact putting themselves and others at a very, very high risk for HIV infection. We've got to fashion our prevention measures that are targeted at the people who are higher risk. This idea that HIV, and we used to say that, there used to be actual signs that say that HIV is an equal opportunity and baloney. It's not. If you are a white co-ed in Des Moines, Iowa, and you sleep with the guy across the hall, the chances of you getting exposed to HIV are so small, I don't even want to say that publicly, because then everybody in Iowa is going to be all jumping into each other's bedrooms. But the fact is that if you're a 15-year-old African-American girl in southeast or northeast, and you have a sexual encounter with someone who's exposed to drugs, who's involved in all the things, the chances of your getting exposed to HIV are infinitely greater. So there's enormous disparities that go along with things like drug use, the drug programs there needs to be counseling, there needs to be better health care delivery, there needs to be routine testing of people. You know, it's interesting, the CDC did something good. They made a recommendation and a guideline that HIV testing should be a part of routine medical care. Namely, it's an opt-out. So when you go in, instead of just like they draw your blood and take a urine, they don't say, excuse me, but can I have permission to do it? You go in and you sign up for a workup, as it were, medically, and they draw everything they want to draw without asking particular permission. We used to have to ask for particular permission for an HIV test. You don't have to do that now, but yet it's interesting because some states still require that you do that. The only trouble is that many of the people who are at the highest risk for HIV don't get routine medical care. So you're still not a big proponent of getting testing anywhere. You know, you go into Safeway and you could, pick up something, a saliva test that can get you tested as opposed to waiting for routine medical care. So there are a lot of things that we could do here in the district.
So still staying domestic and on HIV, I remember not too long ago, Julie Gerberding, who's the director of CDC, whispered in my ear, and she said, Larry, tomorrow there's going to be some numbers coming out that HIV in the United States is much higher than we had previously estimated, and the politicians are out to get, they're not very happy about this. If you and so one of the critiques, and I actually think that Julie's right. It's an artifact of counting, but nonetheless, the point that the make in a layaway is we've reauthorized PEPFAR for $48 billion. We're spending all this, not made more progress with HIV in the United States, particularly in poor neighborhoods.
Right. That's a very good point. And we haven't. It's interesting that you say that, because what Larry's referring to is that we used to say that, back in the 80s, the number of new infections per year peaked at 130,000 in the mid-'80s, late 80s. Then they came down dramatically, mostly through self-education about helping each other figure out what risks are. But then it plateaued at what was thought to be 40,000 new infections per year. The counting wasn't very accurate. When they went back and did better modeling of what new infections were, the new number is 56,300 new infections in the United States per year. And that's the thing that has gotten members of Congress particularly upset for a number of reasons. There was this somewhat little paranoia that the CDC was cooking the numbers so that they wouldn't have to put that much money into it. I really don't think that was the case at all. They're counting it better. But what Larry is getting at is that what about a PEPFAR for the United States, which a lot of people are asking about? The answer is, I would think that's something that we should do. I'm going to testify on the 16th, a week from this week, in front of Henry Waxman's committee on these new numbers and what do they tell us and what we should be doing. And in fact, there is a good argument for having a PEPFAR-like approach in the United States, particularly, and I don't mean in a way that totally singles them out, particularly directed at the African American, because they are so disproportionately afflicted by HIV. The Black AIDS Institute, which is a Los Angeles-based organization whose president is a guy named Phil Wilson, who's a terrific guy, they did a study that Black America were a separate nation. They would rank 16th in the world in HIV infection among countries. So if Black America was a separate country, Black America ranks among the incidence and prevalence of infection among the 15 PEPFAR countries we've targeted for PEPFAR. The incredible irony of it is that since we don't have a strategic plan for how we're going to handle AIDS in Black America wouldn't even qualify for PEPFAR money, because to get PEPFAR money, you have to plan about how you're going to address, and we don't have one. So, I mean, it's just astounding. I know Henry's going to go bonkers, and it's going to be an interesting on the 16th.
Okay, well, let's stick with PEPFAR. I mean, PEPFAR is an incredible achievement, and we were at the White House signing of PEPFAR, and I think there's just a great deal to be proud of. It's inspirational. But one thing that struck me in your talk, I was so pleased that you spent as much time with neglected diseases of poverty, malaria, tuberculosis, as you did with HIV, and also the low-tech approaches as much as you did with HIV and PEPFAR. But do you see a tension there in terms of the United States focus in terms of its international development assistance for health? Because on the one hand, we spend so much for the single disease, which does, and I know it's designed in a way that does think about things like health systems and so forth, but it's really not getting to kind of basic survival needs in terms of mosquito nets and clean air, clean water, sanitation systems, things like that. And so we spend so much, so little on everything else. Even with PEPFAR, we rank near the very bottom in terms of our development assistance for health. So is there a tension?
I think people who are somewhat enlightened are now starting to realize that, one of the things that particularly when you get money that's appropriated from Congress, there's a lot of oversight in how you spend the money. If they want to come back and there'll be a hearing a year or two from now to make sure that you spent money for X. And I think that's good that you're held responsible. If you're going to be given the custodianship of taxpayers' money, you should spend it the way the original law or the original intent of the Congress and the United States government was. The only trouble with that is that it gets very complex with regard to what Larry is saying, in that when you build up for the kinds of things that PEPFAR does with HIV, the interrelation HIV and malaria and tuberculosis and diarrheal diseases and clean water and sustainable health systems, delicate that interaction, that we're starting to see that it doesn't make sense to prohibit the use of building up of medical and other infrastructures, intellectual infrastructures, or what have you, merely by making everything a silo effect. Here's HIV and here's measles and here's malaria. Measles is still a big problem in Africa, and what we're doing is that when to get the measles shots for their kids, that's the best time to give them a bed net to take home to help them prevent malaria, as to do an HIV test to see if the mother is infected. So we're getting much, much better at it. So it started off as very, very strict boundaries between them. And I think now, as particularly with the reauthorization of PEPFAR,
Makes a big difference.
Big difference.
Makes a big difference.
Yeah.
And it is a big difference, and I think nobody can underestimate the value of PEPFAR and in its targets and health systems and things. On the other hand, I wrote this down because I'm writing a commentary for JAMA on PEPFAR. I have a hard time writing it because I've got this cognitive dissonance about it. And I wrote down your striking statistics of for every one person that we treat, was it? That
Right.
2.5
2 to 3 people get
newly infected to PEPFAR, and you see the preference for treatment, and then even with prevention, the spending for abstinence and other kinds of programs. I know you speak for the administration. I don't want to make things awkward, but
No.
again,
I speak for myself.
Okay, is there a tension there as well?
No, I mean, the whole issue of abstinence, being 1/3 of
And
the 20%.
and treatment being so.
As you all know, you live here, you study here. Washington is a place of compromise back and forth. If they hadn't put in the original PEPFAR designation that 1/3 of the prevention should
wouldn't have
be of
gotten it.
abstinence, with no disrespect to anybody in the audience, all of the real conservative people in the Congress would have never voted for it. So
That's
you
right.
had to throw a few crumbs here and there to get it through. That's what it's all about. That's the compromise. I mean, the idea of having abstinence only be a major component of it. I was against that from the very beginning, and I argued with the people in the White House that they shouldn't do it, but they explained to me that we may not get it
We
through.
didn't get it.
The one thing that we won, that have gotten through, and this is the truth. I mean, I had a conversation with the president. I said, Mr. President, if we don't do this, it's going to be the laughing stock, with the idea about paying for condoms, because of some objections that some groups had. I said, if you have a prevention program without condoms, you don't have a prevention program. He actually agreed.
Mm-hmm.
And PEPFAR has given out something like 3.5 billion condoms since the beginning back in 2003. So that was a good thing. So, you take some victory.
And it's part of the
It's part of the game.
Yes,
Right.
I think it was Coburn who I'd read an editorial. I think maybe in the New York Times, where they said they had hated what he did in holding up PEPFAR.
Right.
When actually to talk to him, they said, well, I'm only holding it up because I want to make sure that enough of the money goes for treatment.
Right.
Now that's it's difficult because you can't really say, oh, it's a bad thing that we're saving this young
Right.
mother's life by giving her treatment. But on the other hand, how many more
Right.
preventions,
Okay.
HIV preventions, can you save? And so it's this rescue, it's the individual rescue versus the population.
You could weave this into your JAMA commentary.
I'm writing.
If I might make a suggestion. And the reason I say that is because I'm preparing for this now, because Henry Waxman is going to ask some real tough questions about
He
what
always
we're
does.
doing for prevention.
Because Tim will write them.
But he's usually right in saying, you know, about the issue with prevention. But one of the issues with prevention is that has so much to do with behavioral modification, and it is very, very difficult to get behavioral modification when it comes to sexuality in societies in which there are things traditionally that mitigate against the kinds of behaviors that would keep you out of risk, and who are to the whim of a man in a society that's totally male-dominated. I mean, how do you prevent a wife at home from getting infected from a husband who's on a truck route and gets infected and comes back? She says use a condom, she gets beat up and thrown out of the house.
And Jonathan Mann would have said the biggest global health issue is
Absolutely.
and their human rights.
There's no doubt. There's no doubt. So the reason I say that is that when you put money into treatment, you get the drug, you give it to the person. There's no doubt that's a slam dunk. They're going to get treated.
If you can retain them as
If
well.
you could
and
retain them,
sustain
but prevention has this
tougher.
vagueness about it. I mean, what is there really a relationship between education and behavioral modification, or not? I don't know.
I don't know either. Well, let me just transition to a couple of other issues, and then we'll turn it over to our students. Tell me, in terms of fighting an emerging infection, tell me what you learned from SARS and how you might have applied that to a potential highly pathogenic influenza. And in relation to that, talk a little bit about the long problems we've had with vaccine development in the United States, which I've heard you speak very articulately at the IOM about. And then we'll turn it over to the group.
So SARS. SARS is an example. We didn't have SARS came rather abruptly. You remember SARS. It was the thing that started off in the Chinese didn't talk about it, and then someone who was in China in Guangdong province went to the Metropole Hotel in Hong Kong and then infected about 9 or 10 people in all their places. One of them went to Toronto, and Canada is still reeling from that because it economically really hurt Canada. It was a self-contained disease that wasn't nearly as well transmitted as influenza, which is a transmissible disease. What stopped SARS was low-tech 19th century public health measures. You get off planes if you have a fever, see a physician. You should be keeping yourself out of contact with others. There was no drug, but just monitoring and keeping people out of the kinds of contact that you would get with a transmissible respiratory disease, and SARS went away. And it didn't sustain because it was one of those things, 70% of the new emerging infections are what's called zoonotic, which means they're really animal infections, and through a mutation of some sort, they jump species and then adapt themselves to a human. Many zoonotics, they'll jump species, but they don't adapt very well to human, and then they die out. That was exactly what happened with SARS, because if SARS had been a sustainable mutation, there would have been continuing SARS, and there isn't, so SARS is out. So what did we learn that might help with pandemic learned is monitoring is probably, and international cooperation and transparency is probably the best thing that we could do. It also got us to modernize our vaccination development programs, because we have a tough situation in the United States, particularly with influenza, that's seasonal influenza. Manufacturers do not like the idea about getting involved in vaccine research or vaccine development, because vaccines are not big money makers for them at all. It's really economically not sound.
Unless it's human papillomavirus.
Right, exactly, unless it's human papillomavirus, where everyone will take it.
Yeah.
Right. Anyway.
A little bit about what you've done in terms of trying to advance vaccine technology in relation to H5N1.
Yeah. Situation of how are we going to respond if, in fact, this H5N1, which is fundamentally a bird virus that's devastating chicken flocks in Asia and rarely jumps species to human and virtually never goes from human to human. So if you're a chicken in Southeast Asia, you have a serious problem with H5N1. If you work on a chicken farm, you better be careful, because it could jump species. Since 2003, which is 5 years now, there have been 380 cases of human H5N1 with about 200. So it's highly lethal when you get it. So rather than just focus on H5N1, we were asked certain questions by the Secretary of HHS, by the White House, by the Department of Homeland Security, which gets involved in these things, is that if we had an explosion of H5N1, what would you do? So we looked at our vaccine production capacity, and we started asking questions that we never asked before, because it wasn't particularly relevant. That we still make influenza vaccine by growing it in chicken eggs, in which you harvest it, spin it down. It's a very convoluted process that's expensive, that's prone to contamination, and that is very, very difficult to surge up in numbers of doses that you want. So we had to make a switch from egg-based to cell-based. We also had to develop capacity to manufacture country. Before, we could only manufacture about 50,000 doses. Now we have the capacity to manufacture a couple of 100,000 doses. So in an interesting way, worrying about the explosion of pandemic flu has prompted us to modernize and bring into the 21st century our capacity to make any kind of vaccine, particularly vaccine for seasonal flu. And vaccine for seasonal flu is very serious. We have 36,000 deaths per year in this country, 200,000 excess hospitalization, and billions of dollars in economic loss. Flu. And we don't handle seasonal flu right. Many people who need to be vaccinated. So now we're starting to vaccinate a lot more people, and it was in the newspapers, I think, yesterday, or maybe, that the CDC now is going to be pushing to vaccinate even children who would normally be at low risk of getting seriously ill, because it's the children that wind up going home and infecting grandma and grandpa and maybe mommy and daddy if they're older and susceptible to the complications associated with influenza.
Well, thank you, Tony.
You're
This is a beautiful discussion. I'm now going to turn it over first to our students. Lizzie?
Well, the answer is WHO is at the center of all of the global health issues, and virtually any organization that is involved not only in funding but coordinating issues that relate to global health generally does it through WHO. So that's the central organization, except that WHO is in many respects a very, very heavily bureaucratic organization. One of the reasons, actually, when we did PEPFAR, that the president wanted no part of that. He said, we want something that's very accountable and know where the money's going, and we're going to hold people accountable for it. But the answer to your question is that, yes, it is generally coordinated through the WHO. HIV as a subset of that, which is UNAIDS, which is a subgroup which has done a very good job with international. To them, they ask permission to do anything. I mean, the Gates Foundation is doing an extraordinary amount. The Clinton Foundation is kind of like the honest. They do a lot in negotiating down prices and getting deals for bulk to give to a country. I wouldn't say that's coordinated through the WHO, but they generally have a very good feel for what the whole big 30,000-foot picture is. Right.
And I think that conflict applies even more to non-government actors. What I have in mind is the Bill Gates Foundation, and if that foundation is so huge and so influential, I might feel that may distort the priority for spending.
Yeah.
Small philanthropic organizations, small other organizations might hesitate to go into some fields, fearing that Bill Gates Foundation may come in the future and dominate the field.
Right.
So I would like to ask your opinion on those potential negative effects of those huge foundations.
And that's something that we've actually discussed and in some cases struggled with. There is a perception among some, and I think there, that the Gates Foundation's contribution to global health is so enormous compared to any other NGO or non-government organization that they tend to set the trends of what should be done with what disease. And there are some that say, since they have so much money, what they might do is figure out, rather than saying, we're going to do malaria and we're going to do HIV, to try and get them involved in other things that actually might benefit just as much, such as diarrheal diseases and neglected tropical diseases. That's really what global health are all about. And the young lady who asked me about the coordination, this actually relates to your question, because there are other issues that need to be addressed, and generally private philanthropic organizations do what the leader of that organization happens to be interested in. So that's why it takes things like the United States federal government or WHO to say, we have an issue with neglected tropical diseases. We did that ourselves. We never had a neglected tropical disease initiative until it became clear, as I kept on going back to Africa, my African colleagues were doing a spectacular job on HIV/AIDS. You're starting to do a really good job on malaria, but we also have a lot of other things that are issues here. One of them is the neglected tropical disease. So now we have an initiative on a neglected tropical disease. So your point is very well taken, that the giants of philanthropy tend to dominate the field and might skew it in a way that doesn't really make sense for the big picture of what you're trying to do globally. The other issue, the one that I've gotten interested only because every time you start talking to people and reading it, you see something that you're not doing. It kind of keeps you up at night, actually. There's never Miller time when you're doing this. It's always something else that you have to do, is the whole issue of clean water and all the diseases associated with clean water. It might be a good idea for $1 billion or so of the Gates money to go and start worrying about clean water.
It would be a great idea.
Yeah.
As a follow-up question to that, I know that the NIH spends less than 1% on allocation of U.S. NIH money, or is it more sort of that the science isn't
No,
necessarily
that,
there?
it's the latter. When you're trying to jumpstart a field, you have to get a cadre of investigators that are interested in it, and you've got to fund them. And then, as scientific opportunities emerge, that's when you get the explosion. The same thing is years of HIV/AIDS. You say, "My God, this looks like it's going to turn out." I mean, I thought it was. I was terrified it was going on in the early '80s. If you dumped in billions then, you wouldn't even be able to spend it. So what you need is sustained commitment, build the intellectual and in some cases physical infrastructure to lead to the opportunities. We're doing that with malaria. Unfortunately for the NIH, the last 5 years our budget has been flat. But if we were going through the doubling 1999 to 2003, the NIH budget doubled, which was fantastic. And then we went through 5 and now going into our 6th year budget. So as the opportunities and the interest in malaria research are starting to really get going, the only way that I'm going to be, and I'm responsible for more money into malaria, is to take it away from something else. So the time you need to grow it is when the at a reasonable rate. But malaria is entering to that stage where as soon as new money comes along, it's going to be much, much prioritized to malaria. Malaria is the critical issue now, not only in research, and the critical thing with malaria research is to get a vaccine. I mean, we got good drugs against more. Soon there's going to be resistance to the good drugs like artemisinin derivatives, which are the best drugs now for malaria, and we need to have a better pipeline because there will be resistance. But a good malaria vaccine, there are multiple companies and multiple investigators that we're funding, and if I get more money, I'm going to fund them even more to move forward.
Yes.
My question is, how can, are there any specific measures that EPFA and other organizations have to ensure that the money that is being channeled to sub-Saharan Africa will be going to the people who need
Yeah.
it most?
Yeah.
I'm actually from Uganda,
Yes.
and I've witnessed that a lot of global fund money and government funds were misappropriated.
Yeah.
And what happened was the funds were suspended,
Right.
and then there was a commission inquiry. But
Yeah,
then the
I know.
people who need the money,
Right.
get the money, who actually misappropriated the money have not.
Right. And global fund spending was suspended from Uganda for a while for that. This, you are expressing what I would call the exemplification of the discussions that I had with others during the time that I was putting together PEPFAR, is that the president insisted, I don't want anything that's not accountable. We don't want to give any money to the government. We're going to give money directly to the organization that's going to deliver the treatment. That could be Médecins Sans Frontières, that could be anybody. We're not going to give it to the government involved because then it's not accountable and we have no idea where the money is going to. So a lot criticized him for that, but at the end of the day, he was correct, whereas the global fund money sort of went to Uganda and went to the ministers and badly misappropriated them. So PEPFAR money doesn't go to any government, period.
Okay, one last from our student, and then we'll open it up to others.
I have a question. Influenza. Since it isn't a pandemic disease that deal with human health as well as animal health, a lot of organizations must coordinate their efforts. I see that in North America you design a lot of protocols and plans to stay inside the country in case that you have the influenza right here. But how do you feel from that? We do a lot of efforts. We get together with international organizations. We don't have the infrastructure to attend an emergency. You know, because we can work very hard, we can learn a lot from developing countries, but when a real emergency may be arrived, there is not much that we I always wonder if all this money that is good for training, for the capacity, we don't have the infrastructure to.
No, it's a very good point, and that's the reason why when we do research now, it's very different than it was 25 years ago. Right now, we make it very, very clear we, in partnership with any country, particularly developing countries, explicitly developing countries, is that you have to do it in a way that leaves in the country the sustainable capability of doing it themselves when we go. There was a phrase called parachute science, where we would go into a country, parachute in, do our thing, and then get the hell out, and then leave the country without anything to sustain it. With pandemic flu, it's particularly difficult because right now in the world, there isn't enough capacity to make a small fraction of a % of vaccines that 5 billion people would need if you have a pandemic. That's just not going to happen. But what we can do is that when you're interacting with a country, to make sure that you leave sustainable things like people who are trained well and will train others. One of the difficulties we get into is sometimes you train people and there's nothing for them when they go back to their country, so we're very, there are more Ethiopian doctors outside of Ethiopia than there are in Ethiopia. And this is interesting, embarrassing, but it's true.
Okay, have you asked the question yet? Okay, and then, so we do have 2 more students, and then we'll go. Okay.
My question is regarding HIV/AIDS.
Act out so people can hear.
Okay. I was just wondering, from my perspective, it seems that early on there was quite a sense of urgency, and it was an incredible emergency that needed to be addressed, and a sense of motivation and movement among Americans to really sort of get a grip on it and to stop the spread. Now, from my perspective, it's seen as more of a chronic disease. You can live for a very long time, and with that comes sort of other issues. But I'm wondering, do you think that now that it's seen as sort of a chronic disease, that has taken away sort of that sense of urgency, and in fact, some of that motivation that was felt early on to sort of do something about it has lessened? Some people I speak to sort of seem like, oh, it's not that big a deal anymore. From my perspective, it's still a huge deal. What do you think about that?
Well, I was trying to make that point. There's an excellent point. The whole complexion of how we view AIDS changes and evolved. In the early years, when everyone was dying and in a hospice, it was very frightening to people. Now, the good news is we have great drugs, and if you get access to the drugs, which states have, you tend to do really very, very, very well. So people are living longer, they feel healthy. You just look at the ads for the drugs. If you ever pick up a medical journal, you see this buff-looking guy rock climbing, I'm taking my ritonavir and I'm taking my and Truvada is for me. It's like, gee, this isn't a real big problem. It is. We still have 56,000. The point I was making is that where it is the worst problem in this country is in the African American community. And as all the situations with poverty and health delivery and hypertension and renal disease, it gets off the radar screen. It gets off the radar screen. And that's have a responsibility that we have to address that in terms that specifically goes after that. There's this, I would say sometimes well-meaning, because I'm not so sure how well-meaning it is, this idea about not trying to stigmatize anybody. So you have your prevention and other measures that it's kind of anonymous. You don't know who it's directed at. That doesn't offend, but it doesn't help anybody either. So that's what you have to do. You have to really focus in on the groups that are really suffering the most. Suffering the most is unequivocally the African American community.
And just following up on that, Tony, the New York Times about a year or two ago had this article talking about how long-term use of antiretrovirals actually brought aging, and that we're seeing disease aging in a much younger person. and then it disappeared. Do you?
No, actually, what it was is that living longer with HIV, they were getting the other diseases.
So it wasn't. So it wasn't the effect of the antiretroviral.
no.
Because that's what the.
There's a very, very terrific study that we funded that showed that it is thought that if you take antiretrovirals for a long period of time, you get a lot of cardiovascular and other effects, and you get premature. So we did a study in thousands of people in which we gave people antiviral drugs throughout, and we gave another group antiviral drugs only when their CD4 count dropped below a certain level. So this group was on much, much less antivirals than this group. This group did much more poorly with regard to HIV-related diseases. But strikingly and totally surprising, the toxicities that we were ascribing to the antiretrovirals were not associated with the antiretrovirals. They were associated with being viremic for longer.
So you actually
had less of the heart conditions and less of the...
So the intermittent group had greater heart disease.
Exactly. The people who were intermittent, it was called the SMART study for some acronym or whatever it meant that I forget. But what a great surprise that was, because we were all saying, oh, you take antiretrovirals for several years, you have greater incidence of heart attacks, et cetera. The incidence of heart attacks is from being viremic for a longer period of time.
Interesting. Yes.
You could comment on, you highlighted kind of the role, where prevention is going to have to outstrip treatment
Right.
in order to actually get a handle on the growing numbers. And you also highlighted the early efficacy of activism.
Right.
And then, as kind of the third part of the trifecta, which I was really glad to hear you talk about, gender politics a little bit and certainly class and race and how these things kind of intersect. From your perspective, you were giving advice to activists on the ground or community organizations on the ground in United States urban centers. What would you kind of tell them would be the best strategies for highlighting these things, for doing on-the-ground outreach that is now maybe being funded more in the nonprofit sector in the United States cities than, say, from top-down government?
You know what I would recommend, and I don't even think you need me to recommend it because in these fields already know that, is that I would recommend that the leaders in the African American community borrow a page from the white gay groups that did what they did in the 80s. They were all over the Congress. They were all over the FDA. They were all over the NIH. What we need to do is we need to direct our resources, our prevention measures, our accessibility to drugs, so that we're doing 10 times better than we're doing right now. Also, is to try and remove some of the stigma. You know, we really need to get the African American clergy involved and African American leaders. They tend not to want to do that because they tend not to reflect attention to the particular problem in their community. I'm waiting for Barack Obama to talk about the real problem of HIV in African Americans in this country.
Okay, let's open it up. I'll come back to the students, but I'll just get some more in the. Oh, Rudy, you want to go first, and then in the back? Yes.
Thank you. Rudy McBride, scholar with the O'Neill Institute and adjunct professor at the School of Nursing and Health Studies.
And long time at the World Bank.
And I'm still thinking about your COVID in Iowa
Yes.
and the CDC recommendation continue testing in healthcare settings without doubt. And I wonder about that CDC recommendation. And I wonder if are there issues here of political correctness where they did not dare to name among whom the epidemic is concentrated in
Right.
the U.S.? And second, if any, was the role, the financial interest of the diagnostic makers behind this policy?
The conspiracy theory of the I don't think so. long discussions with Julie Gerberding about that. There's no way that she was influenced by the people who make the diagnostic test. But what the CDC was trying to do was try and with a net more people than we're capturing. So if it's part of routine medical care, so if you're somebody who's an African American person who gets shot by a drive-by shooting in Northeast, and you go to an emergency room, that's routine. Get an HIV test. Don't worry about counseling. Don't worry about this. Worry about that. Just get an HIV test. And as I said, that's great because your net will be wider, but you won't get the people who don't get routine medical care. Now, maybe that person would not have gotten routine, but when you get shot and you go to emergency room, you get it. So that's what we're trying to do. The issue that Henry Waxman is going to emphasize on the 16th is that problem with routine testing without counseling for people who turn out to be negative. That's a golden opportunity to counsel people about how to avoid getting infected. So that's going to be an interesting discussion that's going to happen on the 16th. I'm wondering how that's going to roll out.
We had something in the back, yes.
I didn't hear the first part. What kind of? Well, yeah, see, you bring up a good point. Immediate post-infection, most of the people, of the 1.1 million people in this country who are infected, 25% of them don't even know that they're infected. The problem is, how do you get to the people to treat them early? We're doing a study that I actually think in my own research with my own group, aggressively treat people very early. You have a much better chance of actually giving a functional cure where you preserve enough of the of their immunological response to the virus and you don't allow a big viral reservoir to form that you might actually be much, much better off. What we are doing in a big trial that's done not only by the NIH but by a number of organizations is a thing called PrEP, which is exposure prophylaxis, or risk reduction, or risk, in other words, treating the risk. Instead of saying don't do a risky behavior, actually treating them prophylactically. So if you have people who are having sex with someone who might be a positive partner or someone who you know is a positive partner, to actually treat them daily with an anti combination, usually 2 drugs, maybe. Tenofovir is one of the drugs, and emtricitabine is another one that they're testing. It's going to be very interesting to see whether that does decrease the rate of infection.
In terms of pre-exposure risk reduction, PEPFAR is doing stuff, or it's going to do stuff in Africa on male circumcision.
Yes.
Any plans to do that in the U.S.?
No.
Why?
Because the majority of people in the United States are, if you look at the United States population, 70-some-odd%
And
of
that would be true in the African American
No,
community?
well, yeah, the answer is less so in the African American community, but clearly circumcision. Let me just, Larry's referring to. We were noticing in important couples in Uganda, in Rakai. You know where Rakai is? Okay. In the Rakai district of Uganda, we have a there. And there are a number of discordant couples where the man is infected and the woman isn't, or the woman is infected and the man isn't. And we looked and followed over a period of time, again, counseling, etc., but even with all the counseling, people still get infected. They were infected and gave it to the men. In a small number, tens or 20, 30, 40, 50. Of the men who got infected, none of the men who were circumcised got infected, and all of the infections were among the non-circumcised. Doing a study of medically supervising adult male circumcision and then following them for a period of time to see if being circumcised decreased your risk. And there was anywhere from a 55 to a 65% protection from circumcision alone. Now we're having a bit of a difficulty because different cultures are relatively more or less amenable to recommending circumcision depending upon what your religious and other backgrounds are. So there's trying to be now an educational campaign to go beyond tradition and religion. And if you're living in a country in which the prevalence of over a certain level, then you want to pull out all the stops for prevention. The United States as a country is not considered a country. It's less than 1% of the population
But
is
Black
infected.
America as a
Yes, that's the point. So how do you, in a culturally sensitive way,
Right.
start telling black mothers they should be circumcising their black babies? That's going to be a tough one.
No,
Trust me.
But I was just,
Yeah.
but I was in Swaziland and South Africa, and that's just what UNAIDS was doing
Yeah.
to the African males.
Right, yeah.
And it was they're actually queuing up.
Yeah.
Yes.
Hi, I'm glad you raised the issue of male circumcision and the response of the Swazi government. So that, as you know, one of the key studies was done in Orange Farm.
Right.
We don't yet have a policy, which raises the question I want to ask you, the difficulties of translating science and scientific research into policies and programs. We gave the example of male circumcision. Another example where the groundbreaking research on early infant treatment was done in South Africa. Percentage, we don't yet have a policy.
Yeah. Well,
So how do I translate?
yeah.
And if I can just follow that up, link to the points you made earlier about PEPFAR and the real translation. I can understand when there was a Republican-dominated Congress, how one would have to sell PEPFAR by throwing crumbs, as you referred to it. But in a Democrat-controlled Congress, was it a fear of a presidential veto?
No. You mean,
Things like the abstinence only.
no, abstinence only is out.
Is that gone?
It's gone. Out. Gone.
Needle exchange.
Needle exchange. Okay, needle exchange is a different story. I'll get back to needle exchange in a minute. Commercial sex work thing, out. All the stuff that we don't like is out.
Out of PEPFAR? Or
Out of PEPFAR, out of the authorization.
No.
Yeah, it is. It is out. No.
I just read it.
No.
It's not abstinence only, but it's a list of things. It's not a spending directive, but you have to report to
You can get around it so
You
easily.
can get around
You can
it,
get around
but
it.
it's in there.
Yeah, but it's in there in a very goofy way,
Yes, it's in
where
there in a goofy way, right.
you're trying to strive for a certain percent of abstinence, and you have to report what it is that you do. Like you have to say that you were bad or good, but it's okay to be bad or good.
for goodness sake.
For goodness sake. But the issue about translating into policy, that really depends on the leadership of a country. Some countries immediately translate the scientific observation. With all due respect, South Africa has been a deal for that. Most Minister Manta Shalabalala who has just been really, you're from South Africa. Sorry, she's a disaster. Right. Okay, but God, I love Washington because it's such a complicated place. To show you the complicated nature of it is that the Clinton administration, I was asked to be part of to actually co-chair a group that looked at all on needle exchange to ask two questions. Does needle exchange encourage people who are not injection drug users to be injection drug users or to increase their injection drug use? Second question, does needle exchange help prevent infection? and we did our own meta-analysis of all of the data, we came to the overwhelming conclusion that A, it doesn't promote injection drug use, and B, it does prevent HIV infection. And I reported that to Secretary Shalala in her office with all of my colleagues there. She got on the phone and called up the White House and said, the data is overwhelming, let's do it. And the Democratic White House said, no, we're not going to use federal funds. And there were so many reasons, not that they didn't want it. In fact, Bill Clinton to this day says that was one of the big mistakes that he made. In fairness to him, he said that was one of the big mistakes. But there were so many, even Democratic, liberal, good people in Congress who didn't want that. He didn't want it. Charlie Rangel, who I love, he didn't want it because he felt that that would be giving up on his community. So it's very, very complicated to, the translation. There was the scientific data, overwhelming dunk that this is the thing that we should do. And we didn't do it. It's just, that's politics in Washington. And so it isn't just South Africa.
Let's see. I'm sorry, I'm giving a little bit more preference to our students, but okay, you want to? Okay, so yes.
Susan Holmes with the Biodiscovery main campus. And back in 1999, when I clerked with the Office of the Special Masters on the U.S. Claims Program, which had exclusive jurisdiction of the Vaccine Injury Act. And I was wondering if you could, I don't know if Elaine knows, how much money is actually spent, what percentage of vaccine development is public versus private? That's the first question. And the second one is, why doesn't the federal government consider itself the exclusive developer of vaccines and private money to do production?
To do production.
Private money, yeah. Outsource. You can do development with intramural and extramural programs.
Right.
But, because that's the money hog, and then do the production part, so you can have more production.
Because the industry is much, much, much better at the development of a vaccine than is the federal government. They just are. I mean, they just are. I don't know what the relative figure is. We spend a lot of money on basic science for vaccine. We get the concepts and the ideas, and the companies run with it. I mean, the whole issue with HPV was the fundamental basic concepts of that were funded by NIH funds, and then the company came in, took it over, and then you had a vaccine that's being widely recommended for all young women. Outsourcing it for just production doesn't work. I mean, from the standpoint of developing the concept, they're not going to just do it to be manufacturing it. And the intellectual rights on that, so it just won't work.
In the back, yes.
My question is regarding healthcare or NBC who are affected with AIDS. We know that the lack of healthcare insurance is an issue with access to healthcare. But if we were to have universal healthcare, these politicians these days are proposing, do we still have problems? Because I think in Rio we'll have shortage of and funding for people to go to doctors and different drugs.
Well, certainly universal health care would be advantageous to people who don't have easy access to it, but the lack of universal health care is a contributing factor, but not the reason why we have such a disaster with HIV and in the African American community. It has a lot to do with the environment that they find themselves in inner city areas, people who are infected through injection drug use and don't know it, gay men, black men who are not as accepted in society, corresponding white gay man, lack of the kinds of absence of stigma among the relative degree, and I'm saying this as a white man, but I get it from my African-American colleagues who are absolutely certain about it, the stigma associated with being gay in the African-American community is very much greater than the stigma associated with being gay in the white community. There's no doubt about that. So, yeah, sure, there are openly gay black men, a lot of them, but there's many, 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 many who are not openly out in the open. And that's the problem, because they don't get counseling, and they lead double lives in many respects and are inadvertently infecting people or putting themselves at risk. Well, see, that's the point. It's very, very difficult to change attitudes. So one of the things that we need to do is we need to get African-American leaders, particularly clergy and others, to be out there on the stump talking about how we've got to remove the stigma from not only being HIV infected, but from being gay in the African-American community.
Okay, just a couple of more questions. Yes?
Yeah, quite influential, particularly in attitudes towards commercial sex workers, in attitudes towards injection drug users. Government attitude of that does have a major impact on the success or lack thereof of some of the programs that you do. Criminalizing things, situations that you need to get access to people, and you can't get access to people who are afraid of going to jail.
I have a question that brings it back to the United States and sort of from a different perspective than we've been talking about, more focused on rural health. I work for the National Council of Urban Indian Health, and a lot of our program services for urban and rural parts of Montana and Alaska. And you talk a lot about the impact HIV/AIDS is having on African American communities, devastating African American communities.
Yes.
The fastest rate between diagnosis and death. And the biggest problem that our clients are saying is we don't have. So what would you say that we do just to get the physicians out there? I mean, rural Alaska, we're talking about the closest patient, the closest provider I have to somebody who's on a big pass is about 1,000 miles away.
Right.
We have one person who's diagnosed. We can't get the drugs to them. We can't get them to the treatment. So it goes to the infection.
Yeah. And that's a very, very difficult situation. And, you know, the Indian Health Service in this country needs, you know, I know you just rolled your eyes. You rolled your eyes. I didn't roll my eyes. You know, it is to get more problem in the Native American population. Not messages of prevention, but also access to care and drugs. I mean, in some respects, it's like a third world country. I don't have the answer. I would like to give you a nice answer to that. I don't.
The follow-up question on my end would be, is there movement, because the other problem that we have is just talking about it in a culturally specific way that sort of gets the message across. Sometimes you just kind of hit a brick wall. And they say, no, that's the white disease. That doesn't happen.
Right.
So is there any research that's being done on how to communicate in a culturally specific manner and do that?
Well, the answer is I'd like to say yes, there is, but I don't know, because we don't do that. I mean, that's not the research that we do at the NIH. But it would seem to me that in much the same way as the answer that I gave to the question about getting African American leaders, community leaders, clergy, you would think that when you have Native Americans, that there is a tribal hierarchy, and there are elders in the tribe and people who are respected by the community that could actually go out and start talking about that to them. I mean, it would seem that that's who we got to get to. You've got to get to the leaders. You need leadership when you're dealing with situations like this.
Okay, two last questions, here and then in the back, and then I'm going to call it a day.
Hi, I was just wondering how the government is prioritizing disease surveillance practices around the world, including the third world, China, and what initiatives the government is taking right now, whether they're private initiatives to
Surveillance for disease? Yeah. Yeah. That's what the CDC is really, really good at. They work with WHO. The CDC has representatives, people literally scattered throughout Africa, South America, the Caribbean, and Asia, who are really very heads up about the emergence of new infections. We get into difficulties out of certain Asian countries. China is really a bear when it comes to that. I mean, despite all of the that they've been going through, they still are very opaque when it comes to diseases that emerge. And, SARS was in Guangdong province for, we even admitted that there was something new there. The same thing holds true in Indonesia. Indonesia is getting very reluctant to share samples with us now for a variety of political and other reasons. But the answer to your question is that the CDC is the major organ of our surveillance eyes and ears.
Okay, last question in the back.
You mentioned the highest rates of uncircumcised males in the United States on acne, and also that there is not so much willingness to deal with uncircumcision in African American communities here in the United States. Is there any sort of issues cultural, or are there other reasons why they're actually uncircumcised and they don't?
No, actually, you bring a good point. I was saying that semi-tongue-in-cheek about that would be a real difficult problem to go in and tell people to circumcise if they're culturally not amenable to that, or really is just culturally gets passed down. That's not what you do. I don't think there's been any good studies to indicate why there is less of a percentage of circumcised men in the African American community than is the white community. I just think it's just cultural. You have to be careful if you recommend circumcision to a mother of an African American boy because that would put them at less of a risk of getting HIV infection. There's something about that. Well, there's a lot of other ways that you could avoid getting HIV infected. So why do you want me to circumcise my baby? I'm not even thinking about HIV infection right now. It's the same sort of thing with the HPV vaccine, that a lot of mothers are running into about whether or not they should be getting. Yeah. Right. No, you're absolutely right. And that's the point, that you really do figure out what's going on anyway. That's why I'm very, very reluctant to say anything about it, because I don't have the information base to say anything with confidence.
Let me just say a few things to close. First of all, I think you'll agree we have amazing students. Diverse, intelligent, makes Georgetown Law and Georgetown's whole community very proud. We're very proud of you. And Tony, I want to really particularly thank you. You've been so gracious and articulate. You've all coming questions ranging from DC to national to global to male circumcision to HIV to tuberculosis to HPV and the like. We thank you so much for coming. We're deeply indebted to you.
Thank you.
And now we're going to... And now we're going to have some food.
There's a section in the back that we'd like to invite everybody to, so please stick around. Let's have another round of applause for both the interviewers and
Thanks, John.
wonderful, John.
Thank you. Enjoyed it. Oh, it's a pleasure.
I do remember the exchange.
Yes.
Thank you for answering the question. I would ask about what's CDC doing to track Native American health. I'm part of their TTACs. Yes. I do know what they're doing. on that one.
Okay.
But, thank you.
You're welcome. You're welcome. Hi. You
You
did? Oh.
You're really raising my hand over there. But
I think it's a very good idea.
I had a question about, you actually had more like, legislation for and I could imagine that would be higher, issues where they even beneath the surface. With that said, and tabling the possibility of such a bill, what does studies GCT get to that's United States funded, but I know some of the studies
Good question.
Thank you. I just wanted to say, hi, I'm Danielle.
Yeah.
We've had a lot of email back
You
and
have,
forth.
yes.
And one, thank you for letting me share.
Those are mostly NR.
Pleasure.
Nice.
I've done a lot of work with the community, and so I can see how this well.
I just find out
What the right.
Yeah. On many.
It's so preliminary. It isn't as if that they're testing interventions. They don't even to test interventions in
Right.
And it was like, that's half my career. That's half my career. What I could do with 15, an extra 15 minutes. But I just wanted to say.